started, we have a wonderful speaker for you today, Dr. Rick Player, internal medicine physician over at the Bessemer Clinic. He started with us this year and has been great to work with, and he is going to talk to us about tobacco usage. So, Dr. Rick Player.
Yeah, I'm not sure I can live up to that, but this has been a topic of mine for a good while now. And basically, because tobacco is so important to not only our healthcare system, but our economy. There's an interesting book that if those of you who enjoy reading, you might want to look. It's called The Tobacco or the Cigarette Century. The Cigarette Century. Dr. Blant wrote it. He's a Harvard professor. Worth reading, but it's a big read. But it talks about the economics of tobacco in this country and the political and the social issues that come with that. It's really an intriguing story if you decide to read it. My perspective today is to talk about none of the good, all of the bad and the ugly. Clint Eastwood is one of my favorite actors, and that title comes from one of his old movies. And I just couldn't resist putting that in. But everybody smokes. What I'd like to do is talk very, very briefly about the epidemiology of tobacco use. And we'll limit most of our talk to cigarettes, not chewing tobacco, not snuff, but basically cigarettes. And there's other sources of tobacco are a very interesting discussion in and of themselves. We'll talk a little bit about what's in the tobacco that does harm. We'll specifically talk about nicotine simply because it is the addicting agent. Now, it's a little bit more than that, but it certainly is a thing that gets people attached to smoking. And then we'll talk a little bit about the health consequences of tobacco, and then very briefly about smoking cessation. I basically give talks just on smoking cessation alone, and so we won't spend a lot of time on that, but I'll give you a few comments about that. When we look at our overall health system and the kinds of things that cause people to die or to be ill or to be disabled or to become unproductive, the leading cause of preventable death in this country is tobacco. And you would think that we'd be able to fix that. I mean, this is not new information. This has been going on for years and years and years. But we don't seem to be able to, we have trouble just getting municipalities to pass non-smoking legislation. I mean, it's really intriguing to me how such a major health issue can be such a difficult problem to solve. Almost 500,000 people die a year related to diseases that are caused by tobacco. Over 16 million suffer from diseases. And that's, if you look at the bottom of the list, that's more than all of these entities together. We get really excited about HIV, and don't get me wrong, we should. But if you look at the deaths caused by tobacco, it includes all of those things and more. But it doesn't get the attention that it should. The actual prevalence of tobacco has decreased over the past 10 years a little bit. Most populations. If you look at patients who have psychiatric illnesses, depression, anxiety, some of the psychosis like schizophrenia, they're still up pretty high. They're probably in the 35 to 40% range. Men have decreased down to about 20%, women down to about 15%. Women probably peaked somewhere around 15 years ago and have kind of slowly been trickling down. Along with that in women came a significant increase in lung cancer, particularly adenocarcinoma. In fact, adenocarcinoma now is probably the most common cause of cancer deaths in women, not breast cancer. Lowest among Asians, highest among American Indians, Non-Hispanic blacks about 18%, and non-Hispanic whites about 19%. Interestingly enough, with African Americans, even though African Americans smoke fewer cigarettes per day, if you measure the urine byproduct of nicotine, it's higher in African Americans than other populations, and we're not sure why. It's also interesting that African Americans are disproportionately affected by the health consequences of tobacco than other races, and it's not clear why that is. The overall prevalence changes with education level. The lower the education level, the higher the prevalence of tobacco use. It's highest among people that live below the poverty level, somewhere around 28, 29%. Those that live below the poverty level, about 17%. And we've talked about the number of deaths, and this data is probably about 6, 7 years old, and I suspect these numbers are considerably higher. And the biggest disease categories are going to be cardiovascular disease, particularly acute MI, and respiratory diseases, particularly cancer, lung cancer in particular, and COPD, emphysema. There's not a portion of the body or an organ system in the body that's not affected by tobacco, including women who smoke, who are pregnant. Interesting about women who smoke that are pregnant, typically will stop smoking during the time of their pregnancy, but immediately after that pregnancy, they started smoking again, and they are a very difficult group of people to adhere to smoking cessation programs. The economic cost is tremendous, about $167 billion annually, $92 billion in productivity loss from premature death, about $76 billion in healthcare expenditures. This data also is about 4 or 5 years old, and I suspect these numbers are considerably higher now. This is a cartoon from Bob Rogers. His father was a pulmonologist extraordinaire, but Bob writes for the New Yorker magazine and puts his cartoons in some of the medical journals, but it would be a lot easier if you would just heed the doctor's warning not to smoke with your oxygen tank. And actually that's very common. I have plenty of patients, both who have nasal cannula and who have trachs in place, who continue to smoke with their oxygen on. And every now and then you'll hear a horror story of their face being burned, or their chest hairs being singed, or blowing up their house with their oxygen. Cigarette smoke, nicotine is just one of the chemicals in tobacco, and it's just the addicting agent. Now, it does do some things independent of being an addicting agent. I mean, it causes vasoconstriction, it causes platelet activation, and so that's one of the reasons why tobacco smoke can result in acute MI in patients who have coronary artery disease. But these are some of the other byproducts. In fact, there are about 4,500 chemicals in tobacco smoke. And this is just some of the heavy metals, cadmium, which has been associated with carcinoma, arsenic, lead, acetone, hydrogen cyanide, and my favorite is formaldehyde. And I always tell patients about that, and they have this bizarre look on their face when you think about embalming fluid being in cigarette smoke. But ammonia, benzene, and these are all bad boys. They do harm to the body. Now, don't be misled about the significance of nicotine. I mean, it really does some wonderful things for people. We have nicotinic receptors in our brain, and so in about 8 to 10 seconds after a patient smokes, the nicotine attaches to the receptors in our brain and causes a release of neurotransmitters. And these are some of them. This is not all of them. But look what they do. Dopamine, pleasure sensation, suppresses the appetite, arousal, appetite suppression, arousal, cognitive enhancement, allows people to focus and concentrate a little bit better, learning, memory enhancement, mood modulation is what serotonin does, so it sort of balances them out, smooths out the anxiety a little bit, suppresses the appetite, reduction of anxiety and tension. Those are all things that make people feel good, and they enjoy that. And that makes it so complicated, because once they become addicted to the nicotine, it becomes it's more than just a hand-mouth habit then. It's truly an addiction. Now this is just a cartoon of that, but it just shows you how the nicotine attaches to the nicotinic receptors and the cause and results in the release of the neurotransmitters. And those sensations that people have from that are real. And most patients will tell you that. If they withdraw from nicotine or if they don't smoke, and most people, it varies tremendously how long it takes for them to start having withdrawal symptoms after they stop smoking. For some people, it's 12, 14 hours. Others, it can last up to 2 weeks and they'll still be withdrawing. But they lose that sense of euphoria. They have a depressed mood. They have difficulty sleeping, anxiety, frustration, angry, kicking their dog, the house, anxiety, difficulty concentrating, just inability to focus. I was on an NIH committee some years ago where we were putting together some guidelines for management of asthma in the elderly, individuals over 65 years of age. And the leader of the group was, I won't call his name since it's going to be recorded, but he is a very, very prominent and well-renowned pulmonologist. And he was always really on task and target for everything we did in the group. But this one day we were in Chicago, and he flew in, and we started the meeting, and he was just disheveled, and he didn't make much sense, and he wasn't focused. And all of a sudden, he just said, I need to take a break. And so he left the meeting, and he came back about 30 minutes later. And I kid you not, it smelled like he must have smoked a pack of cigarettes that period of time. But when he came back, he was focused. I mean, he was right on task. And so nicotine is really, really a very potent drug. And when those patients don't have it, or individuals don't have it, they really have these withdrawal symptoms, and they're real. And if you don't treat those, it's very, very difficult to get patients off of tobacco. Now, there are a few people who can cold turkey. Those are the exceptions, not the rule. Talk just very briefly about some of the health hazards of tobacco. Most of you know these: sudden death, acute MI, lung cancer. And the sad part of the lung cancer, now things have changed a little bit now since we're using CT scan, low-dose CT scan now to screen patients who are over 50 years of age who have a greater than 30-pack year history of smoking for lung cancer. But prior to that, all we had was a chest x-ray, which is very, very insensitive at picking up early lung cancer. And so people who smoked and got lung cancer, I mean, we typically would pick it up very, very late. And the stage was usually high, and the mortality was usually very, very high. Now, it's too early to know whether the CT scan is going to change that. I think it will, but it's going to probably be a while before we have that data available to us. But that's, unlike prostate cancer or where we have a PSA, not perfect, but it is helpful. Mammograms, not perfect, but it is helpful to pick up early breast cancer. We never had that for lung cancer. So the people who smoke really put themselves in harm's way. Emphysema, the incidence has increased significantly. Just a tremendous cost to the healthcare system in managing patients who have moderate to severe COPD. Don't think it's just the heart and the lungs, but the GI tract is impacted by tobacco. In fact, I mean, there's really not an organ in the body that doesn't suffer some of the adverse effects from tobacco. Reduced fertility, premature births, low birth weight, all of those things are related to the use of tobacco. Oral disease, including actual tooth loss. And in fact, there's been one of the commercials on television recently where they talk about, to young people at least, the loss of their teeth. Hopefully that will get their attention. The tobacco industry has been incredibly skilled at advertising. In fact, they probably taught most other people how to use effective advertising to impact the behavior of a population of people. They targeted men, you know, macho, mustache, beard, rugged, horse, you know, climbing the mountain. Women, you know, you come a long way, baby. Kids, African Americans, I mean, race, I mean, they really have been very skilled at and been very successful and made a lot of money on the backs of sick people. We also talk about lung cancer in regards to tobacco, but just know that there are lots of other cancers that the risk for those cancers increases significantly in those individuals that smoke. Urinary tract cancers, oral cancer, esophageal cancer, pancreatic cancer is one that comes to mind, which is a dreaded cancer because there's just really not a good screening test, and most patients don't have symptoms until the disease is far advanced, and so it's really a big problem. But liver, kidney, probably the only thing to mention here is that the relapse rate after the patients deliver their baby is very, very high. Most women who are smokers prior to getting pregnant will stop during pregnancy, and once they deliver, they immediately start smoking again. And they are very, very difficult to enact cessation. I'm going to skip over some of this. So, you know, what can we do? And these are just major things that one can do to decrease the incidence of smoking. Restriction of minors' access to tobacco. And you might say, well, how do you know that works? Well, I mean, there are studies that have shown that it works. Interestingly enough, if young people don't start smoking, or if they don't start smoking before the age of 20, they are very, very unlikely to smoke as adults. So targeting kids, if we can prevent them from starting smoking early, they're unlikely to be smokers as an adult, and that would be a really, really have a major positive impact on public health. Some of this is going on now, restriction of smoking in public places, but it's a political issue. It's a privacy issue. It's a personal freedoms issue for people, and so a lot of municipalities have had major problems in enacting legislation to stop people from smoking in public places. But I think there's some traction now, and so I think hopefully at least in most places we're moving in the right direction. Restriction on advertisement. If you'll notice that a lot of the magazines, particularly the sports magazines and all of those, you see very, very few advertisement for tobacco products in those now, which I think is very, very helpful. And one of the things that I think is important is increasing the price of tobacco with taxes. And you might say that that's cold and hard. Well, no. Because I think when you do that, you decrease the number of people that smoke, and you save lives, and you save pain and suffering. And so, despite the fact that a large percentage of these individuals are going to be on a lower economic status, I still think increasing the price of tobacco is a good thing to do. I'm not going to go over that in the interest of time. And so when we look at people who smoke, what we know now is that if every time they come in contact with someone in the healthcare system, if we query them about whether they smoke or not, and how much and how soon they smoke when they get out of bed, which helps to tell us about the amount of nicotine addiction that they have. For instance, if a patient smokes within 30 to 40 minutes after getting out of bed, they have a significant level of nicotine addiction. And so you know those people are going to withdraw when they stop smoking, and so you might as well come up with a plan to manage that, to help them with that. And so there are some people really believe that you should not use pharmacology for smoking cessation, just to tell you that. I'm not one of them, and most of the mainstream people who deal with this topic do not believe that. And so there are three major drugs. There's nicotine replacement, and we'll talk about that. There's Zyban, which is an old, mild antidepressant, and then there's Chantix, which is a nicotine receptor blocker agonist, and we'll talk about that. With nicotine replacement, there's the gum, the lozenge, and we'll talk about those briefly. The gum, I think, is great, but by itself is probably not a good, I don't like it so much. The way I use it, I tend to use the nicotine transderm patch, which gives you sort of a baseline level of nicotine, and then I use the gum for those periods of time when they have the urge to smoke, and so they get a fairly quick rise in their serum nicotine level. Many people have problems with irritation at their gums and upset stomach with the nicotine gum, but if you use it the way I was talking about it, they would only use it briefly and then spit it out. The lozenges are very similar to the gum. The nasal spray is awesome in that you get very rapid and high levels of nicotine, but I don't know, I haven't seen a patient yet that can tolerate it because it causes so much nasal irritation and sneezing and drainage and all of that, that patients just tend not to use it. The inhaler, I don't usually recommend because so many of my patients end up having already asthma or COPD, and it's an airway irritant, and oftentimes they cough and wheeze, and so I tend not to use it. Now, the nice thing about the patch is that it does deliver this level of nicotine. The problem is that it doesn't have the ability to increase the level when the patient needs it. And that's where the gum comes in. So they have the patch on, and then they have that urge, and it will come. And then they can chew a piece of the gum, and the urge goes away, and then the patch continues. If you look at the rates of cessation, and this is over a 6-month period of time, nicotine replacement by itself is probably somewhere around 20%. A stop smoking message by a physician and our staff is somewhere around 10 to 12%. So it's really pretty good. But nicotine replacement by itself is probably not the best. Zyban, as I mentioned earlier, is an old antidepressant, but it really does work reasonably well in smoking cessation if patients are willing to take it. I typically will use it along with nicotine replacement. I think the success rate is better. Patients tend to have a little bit less weight gain. You treat them for about 12 weeks. Now, when we talk about weight gain for people who stop smoking, it's not 40, 50 pounds. The average weight gain is about 8 pounds. It's a little bit higher in African American females than others, but really not major weight gain for most people. And when you talk to people about smoking cessation, that's one of the first things they talk about. Well, if I stop smoking, then I'm going to get fat, gain weight, and it's really not true. Now, this is the darling of smoking cessation programs right now. Chantix is it sits on the nicotinic receptors and blocks nicotine from attaching, but it also stimulates the receptor a little bit. And so it releases some of those neurotransmitters that we told you about, the dopamine, the serotonin. And so people get some of that good feeling from it, not the same as with nicotine, but they get a little bit of it. So a lot of people do not withdraw from nicotine when they're on Chantix because of that. Usually what you do is start off with a tablet a day for 3 days, and then you increase it to a tablet twice a day, and the total treatment is about 12 weeks. I think it really, really works well. On a rare occasion, I will use nicotine replacement along with Chantix in those patients who really start to have symptoms of withdrawal. It got a bad rap when it first came out. There were a few people who reported all of these vivid dreams and suicidal ideation, although I don't know that there were any actual suicides associated with the drug. If you look at some of the more recent data, those complaints are considerably less now, and so I think it's a much safer drug to use. It's very expensive. That's probably the biggest problem. I'm not going to go over that. We're kind of running out of time. Tobacco is a chronic disease, and I think it's very, very important that we treat it as such. And I don't think you can treat tobacco dependence with just counseling and therapy. I think you need pharmacology, and but I think those things go hand in hand. We put together a smoking cessation program, both an inpatient and an outpatient, and got NCI's funding for the inpatient. And what we found is both the counseling, group sessions, and pharmacology, our success rate was somewhere around 35 to 40% in a very, very high-risk group of people, because these were basically uninsured, low-income individuals, and so they were sort of had the highest rate of prevalence of smoking. And I'll briefly mention e-cigarettes. This is Bob Rogers again, but who knows what kind of toxic chemical vapors you're inhaling with those e-cigarettes? I prefer the carcinogen that I know. And there's some truth to that. And just to tell you that we don't know about e-cigarettes, there's not enough data out there. There's clearly more in the vapor than just nicotine. The problem is that there are a lot of products out there. It's not standardized. Some say they know how much nicotine is in the cigarettes, others do not. There have been a few studies that have looked at e-cigarettes, and there are chemicals in the vapor. There are heavy metals and other chemicals that are there that have the potential for doing harm. I mean, in fact, all of the ones that were looked at in this 2013 review have the potential for doing harm. I think the verdict is out. I think the FDA is becoming a little bit more proactive. Investigators are now looking at e-cigarettes more aggressively. They do not have a place in the smoking cessation arena right now. They may, who knows. The biggest concern I have are severalfold. One is that we don't know what's in the vapor. And it was very similar to what cigarettes were like, many years ago. Everybody thought they were safe and it was okay, and now we know that story. Not to suggest that that's going to happen with this, but the point is that we don't know, and we need to be very careful until we have some studies available to give us that information. Secondly, is that kids are using these more. I mean, they are using these exotic flavors in e-cigarettes now. Mango and blueberry and all kinds of stuff. And kids like that flavored. They enjoy that. And so my fear is that kids who would normally not smoke will use these flavored devices, get addicted to nicotine, and then they'll be smoking. May not happen, but that's my concern and other people in the field's concern. It is a very, very lucrative area for the companies that make these. They are, part about it is that they did not have to go through the FDA to put this on the market for people to use. This is just one of my favorite jazz men. He's one of the Heath brothers. I'm a big jazz fan. This is Nancy Wilson. Many of you would probably know her, but she's a jazz vocalist extraordinaire. I think I'll stop here and questions.
What qualifies you as a smoker? Those statistics earlier, 23% women reproductive age smoke. So what checks the box of, yeah, you smoke or don't smoke?
Well, do you smoke one cigarette?
I don't.
Then you're a smoker. Now, the risk of the smoke-related consequences are going to be less the less you smoke. But if you smoke one cigarette, then you're a smoker. Yeah. And when it comes to lung cancer, the likelihood of developing lung cancer is related to PACU history. Same with COPD. That is, the people who, for instance, we talked about the 50-year-old that has a greater than 30 PACU history is at high risk for developing lung cancer. And so that's 2 packs a day for 15 years, or that's 1 pack a day for 30 years. Yeah. So the more you smoke, the more likely you are to have the health consequences of smoking. But if you smoke one, you're a smoker.
And smoke, both my parents smoked. I never smoked. Back in the day, they would have card parties. There wasn't this big rule about don't smoke around the kids. Mm-hmm. So,
The data is a little softer, but it's emerging. Clearly, kids who grew up in a home where parents smoke are at increased risk for acute bronchitis. They're also at increased risk for asthma. Now we know that secondhand smoke also causes lung cancer, and that's real. It's hard to put a real number on it, but it's real. So if, and we're talking about adults now, but if a husband smokes, wife doesn't, because of the secondhand smoke, she's at risk for developing lung cancer, and we've seen that. 90+% of the people who develop lung cancer is related to tobacco. And obviously there's a smaller percent from other things. And then there's an even smaller percent that we have no clue why they develop it. There's a percent of women that develop adenocarcinoma of the lung who are non-smokers, no secondhand smoke, and we sort of don't know why that is. But that's a very, very, very small part of the big picture.
Is there any test like a colonoscopy we take at 50? Is there any test that you can take, like screening?
No, not for the only thing that's available now, and that's been very, very controversial, and it still is screening low-dose CT scan. I've forgotten. It seems like it was probably about 6, 7 years ago when that study was first reported in the New England Journal of Medicine. Basically, study done screening individuals who were smokers and who were over 50 years of age, and a lot of discussion and dialogue in the medical community about the advantages and disadvantages of that. And here's the bottom line. So CT scan is very sensitive, and so you pick up things on the chest x-ray that are not real. So you pick up a small percentage of cancer, but you pick up a lot of other things that are not cancer. And so the question is, how much harm are you doing by picking up things that are not cancer and operating on people who have a benign process versus the few cancers that you pick up? Most people have come out now believing that it's still a very useful test, and that the benefits of that particular test in that population, 50 years of age, greater than 30 pack history of smoking, is a pretty good screening test. And so going forward, we'll be able to see if that sort of helps us to pick up early stage cancer, stage 1. Now, for secondhand smokers, they don't fit into that category, so there's no screening test for them. And a chest x-ray, a yearly chest x-ray has been clearly documented to be inadequate to pick up early lung cancer. So it doesn't help. So there's not a screening test, and that's one of the dangers of smoking. I mean, it's that's why you shouldn't smoke, because there's just no way to predict who's going to develop. Even if you look at COPD, not everybody smokes develops it. In fact, only about 20-25% of people who smoke will develop emphysema, but we don't know who that is. And of that 25% or so, there's another 20% that will have a very exaggerated response to tobacco, and their emphysema is going to be really, really severe. And so they have a significant decrease in lung function really early. I'm talking like 40, 35, 40, 45 years of age. But you can't predict who they are until it starts to happen.
There's one comment here. How to quit smoking cessation. My biggest challenge in the office is how to convince person to take the first step.
Yeah.
Before we even go to nicotine replacement or Wellbutrin, Zyban. And there's a story about that too. And of course, Chantix. You mentioned that outpatient program that you were involved in through the National Cancer Institute. Are we trying to, maybe under your leadership, something here in the UAB Medical West? That would be a great...
I'm just getting the lay of the land here.
Okay.
I've only been here since March, but one of my goals would be to help establish both an outpatient and an inpatient smoking cessation program. And I can give you a little bit more detail about both if you desire. But we had a very robust outpatient smoking cessation program at Cooper Green that I thought was very successful. I mean, we looked at our first 6 months data, and I thought it was too good. It was about 40%. And then when we looked at the data at the year, it dropped some, so it was down in the low 30s. But still pretty doggone good when you consider the consequences. So I think what's going to happen is most hospitals are going to be required to have that, except Medicare eventually. We're going to have both, well, an inpatient smoking cessation program. And to me, that makes sense. There's absolutely no reason to do it, given what tobacco does to the healthcare system. Another problem that we have with primary care physicians, I mean, there's this pressure driving people to see higher volume. You spend less time with patients, which gives you less time to talk to people about smoking cessation issues. And that's unfortunate. And the reimbursement for even giving the smoking cessation message is nothing, almost nothing. I mean, it's really trivial. But it's better than it was, because in the past we weren't getting anything for doing that. So the whole system needs to change a little bit and recognize the importance of this problem. I mean, we talk a lot about preventative health care, but we sort of don't walk the talk. And so I think this would be one area that if we embraced and worked on, we could have a tremendous impact on the health of our country and family and friends. And other questions? By a show of raise of hands, how many people in the room smokes or lives with someone who smokes? I know you don't want to say it now, but I should have asked this at the beginning. Okay. That's it, huh? Oh, well, I'm pleased to hear that. Any other questions for me? But my goal is to work through the system to eventually put together a smoking cessation program. What we were getting ready to do at the other facility we had worked it out for the outpatients in the practice, but then we wanted to move it to the community, initially with county employees, and then for the larger community. And of course, things happen, and we weren't able to make that happen. But that would be the goal. Okay, thank you very much.